at my pie down there, you see that we carry 25% of disease burden, but unfortunately, we only have 3% of the workforce. When I say workforce here, we mean doctors and nurses and midwives and other healthcare professionals who are supposed to be serving people in Africa. Again, unfortunately, when you look at the global budget, health expenditure, only 2% actually goes to that in Africa, and the rest, 98% goes to the rest of the world. That tells you why potentially innovation then could or can give us a chance to leapfrog and ensure we have more doctors, we have more nurses, we have more nutritionists, we have more public health officers who are able to reach out, but also appreciating that we are not able to increase expenditure as fast as we would like because of other dynamics, and therefore innovation then comes in to address some of those gaps as we move forward. Next one, Maura. Next slide. Thank you so much. So in terms of, for us to address those gaps that we know exist within the African context, access of healthcare, distances to health facilities, and challenges, of course, that are related to infectious diseases for many years. We know 60% of the diseases that you see in most of African countries are infectious, but currently, most of us will be aware that we are now struggling with double burden of disease, NCDs, cancers, diabetes, hypertension, on the list. But because of that, and appreciating that the budgetary allocations for most of governments is definitely very low, we've come up with a couple of innovations of digital tools that assist us to do training. For instance, I just want to share this quickly because I want to go to the main one that I want to share with all of us is Jibu. Jibu, which has assisted us for many years to do training for nurses, for midwives, for doctors, certificate diploma. This is a mobile-based platform that is able to work in any context, offline and online. We've now been able to support upgrading of over 15,000 enrolled community nurses to registered community nurses. We are now working with some of those registered community nurses to the next level of BSNs, Bachelor of Science in Nursing, and a couple of other health professionals that we are supporting. So if we want to check, Jibu, Jibu, is an app platform that you can easily get in your phone and actually get into our Amref campus, which used to train. The lady here was one of the best students in Zambia when we did this program there to upgrade nurses down south. Next slide, Nola. But although we have a lot of interest in training, our main focus, as you might be aware, is around communities and strengthening community health systems. And the tool that I want to share with you briefly is called Leap Mobile Platform. If you Google a bit, you'll also find it because we do a lot of work with that. But why are communities so important in Africa? Very, very important. One is because communities are the link between primary healthcare facilities and communities in terms of providing health information, like now during the COVID time, providing information on hygiene, on hand washing, on physical distancing, on use of masks. They are so important. And of course, providing services, doing outreaches within communities, doing health education around family planning and childhood nutrition. But please take note of male participation, which is so important in Africa. Ensuring that men are accessing services. They are partners of they are supportive partners within families, but also very importantly, they are agents of change within their communities. And community health workers are so important in this. And then last but not least, is of course data collecting health data within communities and follow. And therefore, we've come up with a tool that is able to assist community workers to make their work much easier as they do these few interventions and activities and engagements that they do every day within their communities. Next slide, Maura. So the Leap mobile platform, what I'm indicating here in this slide, is a platform that trains healthcare workers and largely community healthcare workers, wherever they are, whenever you need it, you can access it. This platform, we developed it about 6-7 years ago. It's a virtual learning platform which you can use on any device, but largely we like it because you can use it on basic and both basic and smartphones. So for community health workers in rural parts of Africa who do not have smartphones and they have basic phones, they can use this to do some of the activities that I mentioned, to do the follow, to connect with the nurse or public health officer for support and all that. And then this tool is able to do evaluation through quizzes and assessments. So when we have gamification inside here, so you can give performance feedback, you can measure and adapt quickly, you can check what the healthcare worker is doing, I mean the community healthcare worker is doing, what they are learning, whether they are actually getting the concepts that you need them to get. And where they are not able, then you can be able to support, as you can see down here, that there is actually also direct access to learners by CHUs or community health extension workers, the nurses at the health facilities. Appreciating that, of course, in most of Africa, a nurse or a doctor will serve a population of about 1,000 or even more in some cases. And that's just an average. When you go to rural areas where communities have to walk for up to 20 kilometers to access a nurse. If you go to South Sudan, you go to some parts of Kenya, northern Kenya and Ethiopia and West Africa, you see that's normal. So community health workers and giving them tools that they can be able to use to educate women and children and men is so important. So this direct support through their phones then makes it much, much easier for them to do that, and access to information from their supervisors, from the healthcare workers who are based at the facilities. Very, very important. But also, remember, learning happens across even the community health workers themselves, among themselves. So the tool itself allows for collaboration and chat groups. Whether you have a basic phone or a smartphone, you can be able to collaborate and learn from what other community health workers are doing, what they are doing within their units. We call them units where we work in most of Africa. So they are able to learn from each other. They're able to exchange ideas. They're able to exchange knowledge, exchange also experiences on what they are learning and what they are going through, the challenges and the successes that they're achieving. And they promote nutrition, hygiene, sanitation, and all that. Very, very important. But lastly, and very importantly, is that this tool actually is able to correct any records and push it to the healthcare workers who are based at the health facilities. Why is this so important? It's because then healthcare workers are able to follow what community health workers are learning, and the gaps that there could be in the messages that they are supposed to be passing to communities. But again, we use the basic model of Kirkpatrick's to assess this. We assess what the community health workers are learning, how they are applying what they are learning, the behaviors as they work with their communities. But also, very importantly, we're able to track also health indicators and see whether really, when community health workers use this tool, they are able to change health indicators in the community, the prevalence of malaria, diarrhea, pneumonia, and all that. But also, importantly, of course, immunization of children, nutrition, and such. Now, where are we to date? We've been working with a couple of governments in the region, and as you can see down here, we got endorsement from the Federal Ministry of Health in Ethiopia. We've now been able to reach about 5,000, actually close to 6,000 now in Ethiopia, who have been trained. And the good thing with this tool is that when you have a learner on board, then you can we've actually used it to train on COVID, on diarrhea, and a couple of other things. And that means then they are on a platform. And therefore, any time that you want to do training, say on nutrition or some other disease areas or other health areas, we can always leverage on this. In Malawi, as you can see, we've reached already 200. We are targeting to get to 5,000. These ones we've reached with a couple of messages on SRHR, but also we've used this to reach good numbers for in terms of COVID messaging and training for healthcare workers. Appreciating, and I want to stress on COVID because now most of African countries are moving to home-based care. So we found this tool to be very relevant because then in Africa, if you reflect a bit and appreciate that a nurse will see 1,000 people in most of Africa, and actually in rural remote areas, that might be even much, much higher. Then when you get to spiked cases of COVID, which are now being managed at home, community healthcare workers become central in supporting that to happen. This is so important. So in Kenya already, we've reached about 60,000 now. Actually, the new data is around 60,000 in Kenya. In other areas, we want to see whether we can get there. Uganda, we are targeting that 30,000. We've already gotten there also in Uganda. So you can see the countries where this tool is already in use. We are in discussions with the Rwanda government. We hope to get there soon. But also we are we are getting to West Africa, Senegal particularly, because we want to use it both in Anglophone and Francophone Africa, which is really important. We've learned a lot from the work that we've done in Kenya and these other countries, and we think it's possible to actually scale up the tool in a couple of Francophone Africa countries where we have a presence. So very interesting. And focusing on community health systems and at the community level for promotion, for prevention, messaging, referral, and all that. Next slide, Mauro. So having said that, it's not all good for, and just a couple of thoughts on what we think the challenges that we face as we do innovations in Africa. Having shared just one of the digital tools that we're using, two of them, one for the healthcare workers and the other one for communities. One is that we don't see as much government support, structured government support as would wish to have. We see a lot of private sector driven, of course, innovation, which is good. But again, this puts into jeopardy or question the equity question that we have to address, because private sector, definitely the drive might be slightly different from government in terms of increasing access. And of course, the risk of over-innovating, what we call over-innovating, for those who are already covered. What do you do with communities who cannot afford a phone? What do you do with communities who are not currently being covered by any kind of health insurance? If we continue to model and to innovate largely because we see that a lot for urban and peri-urban populations who are able to pay. That's a big gap, and therefore governments need to come in a more structured way. Infrastructural barriers, of course, even as we do the LEAP and the GTAH platforms, we see a couple of challenges around infrastructure. I mean, broadband network in rural and remote areas of South Sudan, in Ethiopia, of course, where you want to use this kind of tool, but then the internet connectivity is not that good, but also the cost of internet is quite high in most of African countries, which then becomes a big challenge. But also the human interface, the training, the staffing that you need. But the cost of maintaining some of the innovations that we come up with is quite a big gap. Software upgrade, equipment, getting technicians who can support is a big challenge. But lastly, and very importantly, definitely the use acceptance of these technologies. Not only the LEAP and the GTAH, but many others that we've tried. Doctors, physicians accepting to use new technology, new ways of doing business, new ways of seeing patients, because we are used to an old way of doing it. And but of course, with the COVID, is teaching us that it's possible to shift to technology, but this is happening definitely slowly, and we need to move faster. So there are cultural, human issues that we need to deal with. Finally, Maura, finally, okay. What would be our take-home message from where we sit, from what we see, our experiences in these countries? One is that certainly there are opportunities to leverage technology to increase access to health services. Certainly there are opportunities. We've seen that with a couple of digital tools, like what I've shared, and a couple of others. However, back to the point of equity, are we innovating for the most in need? Are we innovating for the lady, for the child, for the man deep in the villages of Kenya, of Zambia, or Malawi, who have no access to healthcare? Or are we innovating for peri-urban communities who are easily actually can walk a kilometer or less than a kilometer and access health services? Who are we innovating for? There are opportunities, but we have to keep the equity question deep in our mind. Number two, as I mentioned earlier, we have to have a conversation around infrastructure, around training, around incentives. What to make healthcare workers to use technology? How do you incentivize them to actually use technology? That's important. But I think that point is even more important than anything else that we can discuss this evening. As we design any innovation, as we deliver any innovation, community has to be at the center. It can't be innovation or technology for the sake of innovation. The community has to be at the center. When we reflect on what is happening with the COVID, when we reflect on the big three in most of African countries, malaria, TB, HIV, diarrheal diseases, pneumonia, it's all about community. If we have innovations that make it easy for communities to get information, get education, do promotion at community level, we'll have handled potentially 60% of the diseases, of the disease burden that we see in most of sub-Saharan Africa. We are very confident of that. So community has to be at the center of any innovation, any technology that we come up with. Finally, this will only be achieved if we use a collaborative approach. Government leading the process, very important, but of course the private sector has a lot to play. Entrepreneurs who think innovation, who think business. But again, back to my question of, are entrepreneurs driving innovation and technology for public good, for common good, or for profit? And therefore government has to come in. Civil society to push for this to happen, and of course empowering communities to ensure that they push to be at the center of any innovation, any technology that we come up with in the African continent. I want to leave you with that smile of that lady and that child to say that, yes, Africa is smiling and ready for innovation and technology to advance access to healthcare. Thank you so much for listening to me. Over to you, Gordon. Gordon, we can't hear you. Sorry. Thank you very much. Sorry, Gordon, you're muted.
Unmute. Okay. Thank you very much, George, for your very interesting statement there. I was surprised to learn that Africa, well, not surprised to know that Africa has 25% of the disease burden, but disappointed to know that we had at only 2% of the world expenditure on healthcare of our economies. That is a tremendous gap that has to be filled. And I know that all of you here who are into technologies are trying to find a way where that gap can be closed to a certain degree by technology. So we welcome your efforts there. Very informative presentation. And now, next up is Miss Shirley Motaung. She's South African. She's a biomedical scientist, as I had mentioned before, and she's the assistant dean at Tshwane University of Technology in South Africa, in charge of postgraduate studies, research, innovations, and engagement. She's the first native South African to obtain a DTech degree in biomedical technology. And those of us who are athletes, like me, and those who are getting a little ahead in age or whatever, may have some injuries to their knees or their shoulders or anything like that, we want to hear what she has to say. Shirley, Madam Motaung, it's yours. Your stage is yours now. Please.
Thank you, Gordon. Can we show the slide, please?
Yeah, stand by just a minute.
Thank you.
And in the meantime, can you tell us more about Tshwane University in South Africa?
Okay, for now, I'm going to say, in South Africa, I'm going to say good evening, but if I'm in the US, I was going to say good afternoon. And thank you so much.
Good afternoon.
For me, it's good evening. For you, it's good afternoon. And I really want to say thank you so much for inviting me and to come and share what I'm doing and what I have done and why I'm saying Africa, South Africa, we've got the solution for COVID-19. And I want to explain why I'm saying so, for what I have done, why I can bravely and proudly say to you that we can beat COVID-19 from Africa, from South Africa. Having said that, I just want to share with you what I'm going to do now for what I've already done that has made me to be excited to say, if I was able to do what I have done, nothing is impossible to come with a very same product that can assist in terms of actually curing COVID-19. Hence, I've put my title in a broad way of just to say the role of medicinal plants in COVID-19. Next slide, please. As you said, I must tell you a little bit of Tshwane University of Technology is one of the best University of Technology in South Africa, especially if you want to come and study I'm going to brag about what I'm doing, especially if you want to come and study tissue engineering and regenerative medicine using medicinal plants. You must come to Tshwane University of Technology. This is who we are. Allow me just to share the vision. This is the people university that makes knowledge work, meaning that the kind of research that is done at Tshwane University of Technology, it must be translated. Community must be able to benefit. Next slide, please. Usually, whenever we do something at Tshwane, I'm telling you that Tshwane University of Technology, we have got a mission, and what is our mission? We advance social, which is crucial, economic transformation through relevant, the type of teaching that we do, the impactful of research and engagement, the quality, the learning experience, and dedicated staff and enabling environment. The next slide, please. Next. Can I get the next? Okay. Now, before I come to this, I just want to tell you, I was just telling you about Tshwane University, being an assistant dean, what the university is all about, number of students that you've got, and what you're doing. But for the sake of time, because I'm just giving 10 minutes to talk, I'm also an entrepreneur. I've got a company from my research, and the name of the company is Global Health Biotech. That's got a patent, which I've already have a patent from this company, and that I've already filed it, and I'm now filing it in the US. And the company was founded in 2016 using my research background in plant-derived morphogenetic factor for use in tissue regeneration of bone and cartilage using medicinal plants. So this is what my company is all about. Let me now tell you, next slide, please. I had a dream, just like Martin Luther King. And I'm going to say, I had a dream, Martin Luther King had a dream. You remember Martin Luther King's dream was, I had a dream that one day America will have a black president, and it did happen. And me too. I had a dream that one day I will have a company that can manufacture anti-inflammatory medicine. And this was one of the missions, that I wanted to be a biotech leader in the provision of clinical proven and affordable plant-based products for treating musculoskeletal injuries. Because I know in the US, currently, they're using BMP, bone morphogenetic protein, and it's very costly. And BMP also can also be carcinogenic. So in Africa, South Africa, I actually have a dream on how are we going to do this. I cannot just fold my arms and knowing very well that we are going to benefit. The next slide, please. Next. Oh, okay, go to the previous one. Okay, this was just our vision that whenever you do something, you don't only do it for Africa. And you want to show the world that Africa, from South Africa, we can also do something that can be internationally recognized. That is why it was my vision that the product that I'm going to develop from my company, it must be an international provider of high quality commercial medicinal plants to the middle income marketing suffering from musculoskeletal injuries. And I've said that the reason for that is because I knew that a lot of people cannot afford the type of treatment that they are using in currently. It's very expensive. Now, let me just go to the next slide so that I can just take you briefly what I have done. What my business role did, what we decided to find out, that most of the ointment that you've got in currently in the shops or whatever, those are ointments that you go and head yourself and you apply it. Currently, after lockdown, I'm going to have a lot of clients because people are just sitting there, not exercising, and they're going to have this muscle pain. Because if you can see, working from home, you're constantly sitting, you don't stand up. So what I decided to do, I decided to start competing with certain products that we've got in the market that you know you only apply them. And those products, you have had yourself and you apply them. And then what I did, I use medicinal plants that manufacture a product, and the name of that product is called La Africa Sutha. This is the product that is actually coming from the medicinal plant. You can see nicely packaged, available online if you want to place an order. What this product did, it offers athletes, sportsmen, and women an alternative anti-inflammatory ointment. What it does, it helps relieve muscles and joint aches, soothe sore muscles, arthritis, muscle pain, and targeted pain. And it should be applied and before physical activity. This is what makes this product unique, which is, I can call it their value proposition. That's stood up compared to the Voltaren that we've got, compared to the Deep that we've got in the market. This one you applied before and after physical activity. If you want to go to gym now, you take this, apply it, you're going to feel great about yourself. You even want to go back to go and do exercise because you don't have those muscle spasms. Next slide, please. Now, when Gordon asked me to come and talk about the new toolbox that will help to combat COVID-19, the first thing that came into my mind was medicinal plants, herbal medicine, traditional medicine. Next slide, please, and why? Now, this is just the background just to give you it. If you look at South Africa, and if you look at Africa, currently South Africa has a unique democratic challenges where COVID-19 encounter measures needed to be appropriate, effective, and safe. In herbal medicine, it must make sure that it is very effective and is very safe. And again, due to women and culinary diversity of its population, South Africa, or I can easily say Africa, is rich in native flora that is currently tapped as medicine by traditional healers. And so far, little is known about the natural products of our native that it will have a potential to be used as a remedy for COVID-19. Next slide, please. So little has been done scientifically to validate therapeutic and curative claims of traditional healers regarding many human physiological disorders. So next. So how are we gonna enter, or how healthcare is entering a new era? I can proudly say, use raw materials from plants, but we will not use any other kind of plants. We have already earmarked a plant that's got antiviral activity. And that plant is the one that we are going to test it to positive sample of COVID patient. What we wanted to do, we wanted to explore native flora of South Africa as a source of novel biomarkers for treating COVID-19. Because what is a challenge now with a COVID-19, we don't have a marker. And this is where we don't have a marker that can say this marker is for COVID-19. Because if you've got CRP or you've got, it's for inflammation. So this is what we wanted to do. And we also want to what, because if we're going to manufacture a product the same like Africa Sutha, we have to make sure that we're going to evaluate a purified natural product from the people for treatment of COVID-19 and other related conditions. Next slide, please. So for the how is crucial so that we know how we're gonna do this. And for us to do this, I have already established partnership with the private because we need a P3 facilities, and they're in for that because we all wanted to know what we can bring in. And then what we're also going to do, we have already got the product. I can say I've already got a prototype, I've got the products ready, where we are going to test this and to validate this scientifically, because each and everything needs to be validated scientifically. And I'm proud to say this. In South Africa, we really want a support system where IKS, Indigenous Knowledge System, is being recognized, what is just crucial is to make sure that whatever you're going to give it to the people, the safety, the efficacy has been done. So I'm even proud to say this, that I'm sitting on the Premier Advisory Committee for COVID-19, and they also allow people who always said they've got medicinal plants that they wanted it to be tested for COVID, and I'm the one who's leading that in the Gauteng province. And when we're thinking how we're gonna do this, we're gonna do this in a manner that when we're happy with whatever we have tested, it can either be in the form of the supplement, where we can manufacture the supplement, and then a patient will be able to take it. And the beauty part with the supplement, again, is a preventative measure that you can keep on taking it, that can actually help to build your immune system. Next. So this is now how I always said, I've got a dream that this is going to happen in terms of what we wanted to do. What I can say, our project definitely has the potential to provide data to cure COVID. Definitely this is going to happen, as well as to train young scientists in this scarce skills in biomedical science and biotechnology and phytochemistry. The reason why I'm saying so is because of whenever you are doing, we need to understand that when you do research, you still have also to train young scientists. To do that, as the previous speaker just indicated, that we also wanted to train entrepreneurs so that they will be able to create their film for themselves. So currently, I can even proudly to say, in South Africa, we don't have any other studies that have been undertaken to investigate whether this plant-derived crude extract and their component compounds will have the ability to cure COVID-19. So this is, again, the dream. And I can tell you, on the 9th, today is the 9th of August, 2020, this is what I'm saying, that I've got a dream that I will come with something, either a supplement for COVID-19. And I'm saying it, and I'm proud to say it. I'm saying it today, that in the webinar, I did mention one day that I had a dream that one day I am going to manufacture a supplementary capsule for COVID-19. Next slide, please. I think we come to an end. The benefits of this is that medicinal plants are considered as a rich resources ingredients which can be used in drug development. And sometimes people always get surprised. They forgot that all this Western medicine that we are taking is actually coming from medicinal plants. So definitely, I'm definitely sure that we can use that to develop something for COVID-19. As part of that, this plant also play a crucial role in the developing of human cultures around the whole world. So this is just for 10 minutes that I've just been given, and to try to focus where I'm coming from and where I'm going, and why I'm saying it can be done. Why I'm saying it can be done, because I'm not saying I am going to do it. I can say I have done it based on my experience when I was developing the anti-inflammatory ointment, like Africa Sutra. I'm definitely sure that the very same route that I use to develop that is the very same route that I want to use to develop either a product to either cure COVID-19. And I don't, no doubt about it, it's really going to happen. There, for the sake of time, I've also developed a couple of products from medicinal plants. Some they will be going for animal study that can actually induce bone formation. Some is supplementary that people started to take them if they really wanted to build their immune system. On those few ways, I just want to say thank you, which is now going to be the next slide. And I can just say, next slide, just to thank you all from the blue sky of South Africa, of Gauteng, and I want to thank you all.
Gordon, you're on mute again.
Very inspiring. And I know that you do inspire a lot of South African girls and women. The thing is, there are many people who think of what you are proposing as non-traditional medicine. But one of the things I should point out is that over 30% of the people in the United States use some form of alternative medicine. This is not solely an African idea. It is used in India. It is used in the United States. It should be mainstreamed and it should be investigated more. And I thank you very much, Shirley, for your presentation on this subject. And with that, we will move to a young lady, Jennifer Samboy. She has made her mark in the area of digital technology and artificial intelligence, first at the Sloan Kettering Cancer Center in New York City for over 12 years, and since 2019 for her current employer, Phillips. She is a digital transformation leader for Phillips Digital and Computational Pathology, Precision Diagnostic Solutions. At Sloan, she worked with Phillips equipment and software and contributed to its development while using it. Of course, it impressed Phillips enough for them to want to have her on their team. And of course, Phillips, as you know, is one of the major manufacturers of medical equipment and on the leading edge of the technology. And so I take great pleasure in inviting Jennifer to make her presentation.
Thank you so much, Gordon. I'm very excited to be a part of this webinar today. Great talk so far by the previous presenters, and very happy to share my experience and my knowledge of how we can introduce technology to help in the time of COVID and just for advancement of medicine and patient care in general. So Maura, when you're ready, throw up the slide deck, please. Okay, you could click to the next one, please. All right, a little bit about myself. So as Gordon shared, I have a bachelor's in Science and Technology Studies from Cornell University. I pursued my master's in healthcare administration from Cornell as well, the Sloan program in particular. And I have over 12 years of hospital operations experience, split between radiology and pathology. While at Memorial Sloan Kettering Cancer Center, where I spent the bulk of my professional career, I gained extensive experience specifically in clinical operations and laboratory operations, which are two separate beasts for anyone that works in hospitals and labs. I was trained uniquely enough to respond to emergency situations like natural disasters, but for the record, I was not prepared for COVID. A ton of experience with IT projects and new initiatives, most importantly, leading multifaceted teams like George mentioned earlier in his presentation. The bringing together of subspecialties, experts across all boards and spectrums adds a lot of value, especially when you're introducing new technology. The next piece of that is regulatory knowledge and experience. I had firsthand experience getting our hospital operations, specifically in radiology and pathology, ready for what we call inspections. In the United States, that's a big deal. Everything that we do, especially in the clinical setting, is governed by some type of regulatory standard. And New York State, for those that don't know, is probably one of the strictest. So tons of experience there. And lastly, change management. Whenever you're introducing technology like the one I'm going to discuss with you, it's disruptive. And as someone mentioned earlier, it takes a lot of buy-in. It takes a lot of investment upfront, not only money, but time and learning to get that technology off the ground. So time spent on change management is not little, and it's not something to be overlooked, but rather something that should be embraced and planned for. Just to highlight some of my accomplishments for the sake of this webinar, it's not for the sake of showing off, but just to show you how all of this has led me to what I'm doing today. When I started in radiology, I was working specifically in supporting interventional radiology services, which at the time was still on a paper system. And as you may know, experiencing it in your own entities, paper systems are very difficult to manage, especially when it's time to share information. So that transition was my first introduction to technology, how IT can help solve major problems. Once we did that, we were able to grow the clinic. So it went from maybe seeing 5 patients a week to about 30 to 50 patients a day. We helped create smart orders for both clinical and research purposes. Why is that important? information that's handed from one clinician to the next within the services of medicine essentially impacts how the patient is being treated and cared for. So if the collection of that information is not done seamlessly so that when it's passed on to the next person, you can introduce an opportunity of hurting a patient if you don't have all the information that you should have about that patient. For instance, something as simple as allergies. If that's not properly documented in one of the medical records, a patient could be put at risk if that's not taken into account. For the rest of the talk, I'll focus more on my work in pathology. So for anyone that doesn't know pathology, and I'll describe it a little bit, it is one of the branches of medicine that is the most manual and has not changed in a substantial amount of time. And while I was at Memorial Sloan Kettering, we were managing up to 25 million glass slides across 3 inventory sites with the expectation, because regulatory standards called for it, that we had to retain this inventory for 20 plus years. So it was a cumbersome task to take on, and it had immediate implications to patient care, especially at a hospital like Memorial Sloan Kettering, which focused specifically on cancer treatment. So fast forward, next slide please, Maura. Fast forward, that's how I then ended up at Phillips. So while I was at Memorial Sloan Kettering, as I stated earlier, lab operations are very manual. One of the things that I struggled most with as a healthcare professional running these laboratory operations was having the difficult conversations with patients, clinicians, essentially saying, sorry, you have to wait, we don't have your results yet. And that creates a lot of stress, especially when you know that you need a diagnosis quickly to determine your next course of treatment. Phillips is known and has been around for over 125 years for introducing technologies to this extent. And that's one of the things that drove me to Phillips. As Gordon stated, I was recruited because of the work that I did when I was their customer, trying to improve the technologies that we were using. But ultimately, why I moved to Phillips was because I wanted to do what I did at Memorial Sloan Kettering at a larger scale. Memorial Sloan Kettering is a well-known institution. They're not struggling for funds per se, but we still had the operational challenges of being able to support our clinicians and, more importantly, give patients the information in a timely manner so that they could get the care that they need also in a timely manner. So I joined Phillips in October 2019. I run one of our top 5 initiatives, which is essentially enabling all pathology laboratories across the world to transition into digital pathology. Most important, and what I'm proud of, because we were able to help, especially in the state of New York when we were hit hard with the pandemic, I'm leading the COVID-19 task force team. And our main focus and priority is to make sure that hospitals and labs across the world have the technology in place to be able to continue diagnosing, getting those results to patients and clinicians quickly, but doing it in a safe way. Next slide, please. So what is pathology? In short, pathology underpins every aspect of patient care. The pathologist is the doctor of the doctors. You never hear about the pathologist because they're behind the scenes. We talk about radiology and radiologists being in a dark room just looking at a screen. Well, the pathologists are even in a darker room because they're usually in a basement somewhere with their material under a microscope. But pathology is what diagnoses, it leads to treatment advice, it leads to the development of new technology, and ultimately it prevents diseases. So if pathology is so important, why hasn't technology touched it? Why did it take so long to get there? I mean, pathology, like I stated earlier, has not changed in practice in almost 200 years. And it was only in the last 20 years that we really started to see some changes that was advancing how we treat patients today. Next slide, please. So you take traditional pathology, and sorry for a bit of the gruesome pictures, but you're a patient, you go in for surgery, they think you might have something, let's say a tumor. They remove that tumor. That piece of tissue goes through a series of processes through the pathology laboratory to create what we know as the glass slide or the pathology glass slide. Traditionally and historically, the pathologist will look at it under the microscope and come up with a diagnosis. Today, though, with the technology that's available, provided by vendors like Phillips, and there are many others across the globe, we're now able to take those glass slides and digitize them or scan them to create a digital image. So it's basically mirroring what we did in radiology. So for those of you who may remember, if you went to radiology, you had an x-ray, you got them this film that showed what they were looking at. The film went away because it was unnecessary or an unnecessary expense, and it became burdensome to keep track of all those files. So the idea was, well, if we did it in radiology, why can't we do it in pathology? So fast forward many, many years later, the technology existed almost 15 years ago, but it was only in the last 5 years that we see an uptake of it. And why did we see an uptake of it in the last 5 years? Because of the explosion of molecular pathology. Molecular pathology is essentially taking your genomic makeup, breaking it down to the simplest of details to be able to tell you, here's what you're at risk for. So that essentially led to the notion of what we call today, at least in the United States, personalized care. You can go in, have this assay panel ran, and it runs it across all of your genes and tells you, these are the diseases you may be at risk for. Why aren't we using more of this? Because that technology is also very manual, very cumbersome, and takes a really long time to render results. Furthermore, when that technology became available, it overwhelmed our pathologists and our clinicians. It was just way more information that they can handle. So now you have all of this information at your fingertips, but really don't know how to use it because it's so much of it. So digital scanning was the first step on how we now take this information we already know from traditional pathology, add the genomic layer on top of it. Well, let's learn more with the digital image and try to explore concepts such as artificial intelligence. Next slide, please. So as I mentioned earlier, the pathology workflow is very, very manual. It's not like radiology where the patient comes in, you put them in a machine, you take your picture, they go home. In pathology, patient comes in, they have a piece of tissue removed from their body. That piece of tissue now travels to pathology, and the clock starts when the specimen arrives at the lab. Each of these steps that you see here, within them, there's another 10 to 15 steps, just to show you how complicated and manual pathology could be. And why does this matter? Because when you have a very manual clinical operation, there's a ton of variability and a ton of opportunities for failure and mistakes. So digital pathology hopes to minimize some of that and make this practice of medicine less qualitative and more quantitative. Next slide, please. So digital pathology, or scanning the glass slide, is step one. Now you've digitized the glass slide, how do you actually use it to benefit medicine? The example that I'm showing here are two actual pathologists in New York that worked at Memorial Sloan Kettering with me. And what they're doing is sharing a case via telepathology, which would have otherwise taken us a day or two to physically deliver the glass slides. But instantaneously, all they did was we digitized the glass slide, image is now stored as a record, and they could retrieve it instantaneously within seconds and equally share it just as fast. So what does this help do for us? It expands outreach. Pathology can now get to the places where it's needed most. So George mentioned this in his talk. Are we creating technology for the community most? Pathology, telepathology in particular, did, and that was the intent. Pathology itself is a very hard field to get more people into, maybe because it was perceived as boring and antiquated and too manual. So it's very difficult to get a pathologist in many of these countries. From my own knowledge, in Africa in particular, in the continent of Africa, it is challenging to get access to these pathologists to get diagnoses in a timely manner. So if you introduce something like telepathology, it helps open the access. More importantly, the type of access that you get, subspecialization. Today in medicine, everything is subspecialized. It's very rare that you hear a doctor going into practice and they're a general practitioner. Every clinician today is going in and subspecializing in something. And when you have subspecializations, it's sometimes difficult to get them in your geographic locations. So again, telepathology, like telemedicine, allows more hospitals, more patients to access the expertise that they need to treat their patients. The third benefit of telepathology is improving the turnaround time. It eliminates the delays in waiting for glass slides to be shipped. And I can tell you this was one of my biggest pains in managing a lab operation. We could wait anywhere from a couple of hours to literally weeks and months before we could get pathology material to be able to issue a diagnosis for a patient. This was especially challenging when we were working with countries outside of the United States and they had to ship class slides to us. I can share a personal story. A friend of mine whose dad lived in Nigeria, had a biopsy in Nigeria, was diagnosed with cancer in Nigeria. He decided he wanted to come to New York, Memorial Sloan Kettering specifically, to get treated for his cancer. It took us almost 4 weeks to retrieve the glass slides from the hospital where he had the procedure. And it was essentially us asking a relative of the patient to go to the local community and personally go search for the material. That's insane and incredibly scary and unsafe for our patients. So simple practices like telepathology, digital pathology helps reduce some of that. And lastly, and most important, information sharing. Telepathology allows for more clinicians to consult with one another, discuss difficult cases, and teach. We're using this as a platform for teaching, especially now with COVID. All residents and fellows that are in the field of pathology specifically, they don't have to go into the hospital. They could stay right in their homes and review cases and still continue their training. Next slide, please. So if telepathology is so great, why aren't we doing more of it? Well, it takes a lot for digital pathology to be deployed. And I can tell you that from my own personal experience. It took us years to get it off the ground at Memorial Sloan Kettering. Again, a hospital that is well regarded, has funds. It took us a while. But what I did learn from going through that exercise is we were early adopters. We had to go through all of the challenges and pains ourselves. Now that we know so much, we can share that information with other hospitals and labs around the world so that they can skip some of those steps. But still, the biggest hurdle is the technology readiness to get this infrastructure in. There is no easier way of doing it. I think George mentioned it, internet connection could sometimes be problematic. Having the appropriate IT infrastructure to support this technology could be a challenge. And for us at Phillips in particular, that has been one of the greatest challenges in being able to penetrate and support countries in Africa that are looking to use this technology. But my attitude is, if there's a will, there's a way. We have learned through deploying this type of technology that there's various ways of doing it and still having a successful launch. Next slide, please. So how do we get Africa ready for something like telepathology? There's challenges already with the separation of hospitals and laboratories and just basic processing of specimens that we need to address first and foremost. So how can we do that? Well, I throw out there as an idea, explore the hub and spoke model. Centralize your laboratories, your clinical labs, your anatomic pathologies, because then you can centralize some of your resources, reduce the cost, and really optimize what's available to you. The next is standardize how the lab actually does this work. Lab processes play a crucial role in terms of how diagnoses are completed. So if a tissue specimen that's been retrieved from the body has not been properly processed, what's going to happen is the pathologist or whoever is finally diagnosing that case is not going to have the best sample to review. If you don't have the best sample to review, then you're at risk of calling it something incorrectly. So improving how specimens are processed now is probably the most critical step before we could even talk about IT infrastructure. So then we move on to the next one, the IS infrastructure. It's costly, it is incredibly expensive, but let's look at what are the minimal technical requirements to make sure that the technology is sustainable. And there's ways of doing it. Like I said, we've learned so much in deploying in different countries with different requirements, with different infrastructures, that I'm confident we could find a way of doing something like this in all parts of Africa. And lastly, introducing the new technologies. It's going beyond the installation, like George mentioned, is the ongoing maintenance and support of that technology, the ongoing training and ensuring that the future generations can pick up where we left off. Next slide, please. So in summary, what are the benefits of digital and computational pathology? We organize them into 4 buckets. It improves the patient experience. It could lead to better health outcomes, improves the staff experience for those who are actually doing the work, and ultimately it can lower the cost of care. Just by the simple actions of today, the technology that's available today, it already increases access to care. It reduces the anxiety of waiting for results. I mean, I've had many challenging conversations with patients when they're calling completely antsy, waiting for that cancer diagnosis, yes or no, and it's hard to tell them, sorry, you'll have to wait another week or you'll have to wait another 2 weeks. So being able to answer those calls today and say, yep, we have your results right away, helps with the patient experience. Better outcomes, we know this. It's been proven over and over again. The sooner you diagnose the patient, the sooner they could start their treatment or explore their treatment options. And that helps in ensuring that diseases don't progress and become more expensive to take care of. Lastly, improving staff experience. As I mentioned earlier, in pathology specifically, it's becoming much more challenging to find professionals, technologists, and pathologists that can do the work. What we're hoping is that with the introduction of this new technology, it reduces some of the manual steps that burned the staff out, but also makes it exciting because we're introducing new things like artificial intelligence. And lastly, the most important, lowering the cost of care. We all know that the further advanced the disease is, the more it costs to treat it. So if the end goal of this initiative, of this consortium, is to promote wellness and prevention, then introducing something like digital and computational pathology can help drive that. And with that,
thank you.
Yep, I close, so thank you.
Thank you, Jennifer. That is spectacular. Thank you for making what one would consider a very complicated subject, actually a complicated subject, understandable. I received 2 text messages in the last 10 minutes. One was from a lady who said she wants to get Shirley's treatment. And another one from Ambassador Sidipwaye of Sierra Leone, the ambassador of Sierra Leone to the United States. He just texted me and said, okay, Gordon, I hear all what's going on in Africa. What are they doing in my country, in Sierra Leone? We need them now. So a little later, I will have him come on and pose a question himself. But we have someone who has played a very important role in the United Nations system for UN AIDS. And we all know about the AIDS epidemic, which is the COVID pandemic of yesteryear. And he was a part of the organization that has contributed much to the understanding of AIDS and combating AIDS. His name is Mr. Pradeep Krakatil. He's currently Director of Innovations in the UN AIDS operation. And I would like to invite him to make his presentation. Pradeep, are you there?
Yes, Gordon, thank you so very much. I hope you can hear me now.
Do you have video?
No, I don't have slides, but if it is okay, I will quickly present without a video, without slides.
If you're quite a handsome gentleman, I think we would like to see you on the screen.
My video is on. I can.
Okay.
I don't know if that's.
Or can you
I've switched on, so maybe.
I can see him.
Okay, that's Professor Shirley. Wonderful. Thank you very much for those 3 exciting presentations, and Gordon, thank you for this opportunity to speak. I will be really, really brief, and it's been exciting to listen to these 3 presentations. Maybe if it is helpful, let me do a quick introduction of what I do, and maybe some try to connect some of the different conversations, and if it is okay, I don't know how much time you have for me, but I'll try and be brief. As Gordon said, I work for UNAIDS. It is the joint United Nations program on HIV. And the work that I lead is innovations. And as part of that, we have set up a platform which is called the Health Innovation Exchange. We have presence in 75 countries across the world. And what we found is that HIV has been very much about bringing new ways of working with communities, with technology, with the private sector, with communities and health workers. So what we said is, how do we use the experience of UNAIDS to try and transform healthcare? And what we do as part of the Health Innovation Exchange, and it relates to some of the conversation that George was presenting earlier, is that when you speak to ministers of health, the pain points that they have are very different from what the innovators in the global north are developing. It doesn't really relate to what their real needs are. So what we have been doing is trying to work with the ministers of health to identify what their pain points are, work with the innovation ecosystem to find innovations that can make a difference, and then where you need to take them to scale, to find investors who can actually invest behind it to take it to scale. We have, over the last 18 months, mobilized about $180 million in investment. A significant part of that was for Africa. We have helped one of the innovators set up the largest safety syringe production facility. It's based out of Egypt, but that's one of the largest funding that we have been able to raise recently. So just stepping back a little, and if you would like to follow, we just recently completed our round of 2020 innovations for health. It's available if you go to events. And I'll put that in the chat box so everybody can see it. But what are we seeing in Africa, and particularly related to COVID, but also broader health? What are we seeing? One, we really believe that to a large extent, Africa is coming up with a large number of innovations. Many of them are digital, many of them are mobile, but we see significant innovations. And I'll just take a couple of them. I think George spoke about capacity strengthening. We have seen one of the, probably I would say, cutting edge medical education, which is a blended medical school that's now operating out of Zambia. They're setting up something in Ghana, which is similar. A traditional medical college, depending on where you are, will set you off by, costs about 150 million, 100 to 150 million, and 5 years to set up. These guys are able to set up a medical school at less than $10 million and in less than 6 months. And the quality of education is comparable to the best of the universities. And now with COVID, with most of the education going digital, these guys probably are one of the finest I've seen. The same thing with, I think Jennifer was speaking about digital pathology, but we are seeing use of artificial intelligence predominantly at this point of time in the, what I would say is the imaging space, but it is coming quickly. We are seeing some fantastic financial innovations. I mean, M-Pesa is originated in Africa, but there are so many of those financial innovations, including microinsurance, that we are seeing, which is fantastic. And many of them are really responding to COVID, and it's fantastic to see the role that they are playing. From telehealth, for example, I was fascinated to see, I won't mention the country, but I was fascinated to see them setting up digital dispensaries where the doctor is sitting somewhere in India and the service is being provided in West and Central Africa. So that digitization is making a big difference. And I see that remote healthcare is something which there's huge opportunity for scaling. The biggest challenge that I see in Africa, and it is evident even also in the response for COVID, is twofold. One is the lack of energy. There are several countries that we are working with where 30 to 50% of the primary health centers don't have electricity. Most parts of Africa have 360 plus days of sun, but we have not been really able to do enough to draw on solar energy. So we recently, last week, we announced a new partnership. It is with the International Solar Alliance to focus on solar for remote healthcare. And we believe that that is a critical piece. And that brings me to the second part of the infrastructure, which is I haven't seen very many countries in Africa which have a what I call a digital spine that connects the health system across the country. And that is very critical, whether it is to take up the fantastic technology of digital pathology that Jennifer was talking about, or even just to track the emerging epidemics. If we do not have real-time data, we will not be able to track epidemics. And that is something where we are now investing significantly in providing one solar for health. That's something which we are going to be scaling up. And we just announced that, as I mentioned, it's a 54 member state partnership, the International Solar Alliance, and we are working with them to prioritize that. And number two is, and again, it has multiple benefits. If you don't have energy, you cannot make use of the digital tools that are emerging. And I think for Africa, it's the mobile, which is going to be a huge, I would say, game changer that will help Africa to leapfrog when it comes to infrastructure for health. The second challenge that I see in Africa, and I think you alluded to it, one, we don't see investment, the availability of, I can call it affordable capital, is very, very low. I know, George, you said that it was 2% of the global health expenditures in Africa, despite having a quarter of the disease burden. I also see that the private investment has not really been coming to Africa. And that is a critical challenge, because if you look at the global ODA, it's roughly about $150 billion annual. And it has stagnated at that level for several years, of which about 26, 27 billion is probably for health. But then if you look at the private investment instruments, that is about $300 trillion. So we need to see, because of the scale that is needed when it comes to infrastructure building, as well as investment in health, if we do not get the private investments to flow into Africa, then we will fail. We will not be able to scale at this speed and urgency that is needed. So what we need to be doing, and this is where all of us have a critical role, because what is happening is that most of the private investors are not investing in Africa because of the risk perception. And it's a very false perception of risk, because if you take any of the investors, my apologies if I were to come to North America and ask several people to show where Nigeria is on a map of Africa, at least 3/4 of them would not be able to show where Nigeria is, but everybody would say, oh, Africa is risky. So we need to do a little bit more of educating on the potential in Africa, and to burst that myth that Africa is risky investment. So we need to see how we bring about affordable capital that can be invested in Africa in the health sector to take things to scale. I think maybe just two last points. One, the culture of innovation. I don't think, I personally, I believe that there is enough technology in the world and enough solutions in the world to solve problems. But the challenge is that the biggest bottleneck is that most ministries, be it health or energy or labor or any of these, most ministries are not very creative when it comes to embracing innovation. And that's where I think what we need to really do is to work much more closely with ministries and ensure that communities are at the center of advocating for innovations to be embraced and adapted and scaled. That's one. Number two, I really believe that we need to do a lot more in terms of equity. We recently looked at some numbers. 90% of the innovations ecosystem and investment goes to men, male-led entities. Women are not getting their due share of investments for innovation. But if you look at the most successful innovations, several of them are led by women. So we need to see how we make a shift on that. And the very last point is really the challenge I see with COVID, what's happening is that everybody wants to invest in COVID, be it foundations, philanthropies, donors, everybody wants to invest in innovation, but they're all kind of reinventing the wheel. And that's where I think what we need to do, particularly in Africa, is one, we need to make sure the leadership of the African Union is respected, and the country leadership, national ownership is respected. And we need to ensure that all the different resources that are coming in are better coordinated, number one. And number two, to build on existing capacities. I mean, for me, what is surprising is that if you look at the COVID response, a significant part of the laboratory capacity or the community capacity which exists in Africa has been built through the HIV and tuberculosis investments that have been made over several years. And they're playing a significant role in the COVID response. So instead of trying to recreate a standalone COVID lab or an emergency lab, what we need to do is to invest in existing infrastructure and take them to scale. And again, just one other thing, one final point, Professor Shirley, I come from India, and when you spoke about use of medicinal plants, I was so happy to hear that, because I come from a tradition where we have been using medicinal plants, just as you mentioned, for several years. I'll be very pleased to connect you with the WHO. Has a specific team which works on traditional medicine. If it is at all helpful, very, very happy to connect you. But thank you again. I mean, I really believe that there's so much opportunity that exists, and technology is emerging that can be really a game changer. We need to make sure that we are investing in the right infrastructure, which for me absolutely is about energy and having that digital spine, and to make sure that the communities are driving the ownership and defining what challenges and what solutions can respond to Africa's needs. I'll stop there, and Gordon, thank you so very much again.
Thank you very much, Pradeep. Very interesting presentation, telling us what's going on in different countries to address the poor situation of the poor medical infrastructure with technology, and what UNH is contributing to it. I'm glad that you're connecting with Shirley, and we will also be connecting with you to tell you about our next project, which is coming up, which we call Africa Rise Healthier and Stronger. And we were motivated to develop a project, not simply because of the COVID-19, but then we realized that we needed to do something for Africa that was long-lasting, that would upgrade the infrastructure, especially in the underserved communities in the remote areas. So that is what we are focusing on next, Africa Rise Healthy and Stronger. You will be hearing that in the coming weeks. And that is something that we are planning to launch on October 24th, which is United Nations Day. It will be a virtual event with the live component in New York at the Brick Theater, and with participants from around the world. You will know more about that, and we will ask for your support. Anyway,
look forward to it. Thank you so much.
Anyway, we will move on now. We are a bit behind time, and I'm going to urge the next speakers to be as brief as possible. I'll tell you why. In webinars, at a certain point, people begin to drift away. And we want your presentation to be sharp and clear and captivate the audience so they don't drift away, and get through with your presentation. The next person who we will have up is another young lady, one of whom continues to assure us, all the teenagers like myself, that the world is in good hands once we get past the immediate. She is Leila Al-Nayadi. And Maura, can you get the screen back? Yeah, she is Naya NAIADI, from an organization which is called Health in Your Hands. Health in Your Hands is a global partnership of organizations and key leaders building health ecosystems around the world from various disciplines of health, policy, finance, and development. And back in April of this year, Health in Your Hands presented 10 innovations that they thought would contribute to better health for global citizens. Leila, it's your turn. And by the way, I know you will have two presenters with you. I would like you to introduce them as well, and as briefly as you can. Thank you. Please go ahead.
Thank you so much, Mr. Tapper. I appreciate your introduction, and I'm very excited to be here. I'm very pleased to be on this webinar and hear such excellent presentations from such distinguished experts about technology and innovations in healthcare. So thank you so much, and thank you for inviting me to be a part of this, as well as our two innovators who are joining us. The project I'm presenting specifically looks at innovations in healthcare, as you mentioned to us just now. Health in Your Hands, for which I am the Global Impact Fellow, is under the umbrella of an initiative called SDGs in Action, which is by the United Arab Emirates. And SDGs in Action is meant to incubate innovative projects that achieve the Sustainable Development Goals. The UAE's Global Council on SDG 3, which of course is to achieve health and well-being, which we all care about here today. It developed Health in Your Hands as a platform to showcase innovative health solutions to improve health outcomes and to give access to health to people most in need. In fact, one of the co-founders of Health in Your Hands is on the panel of experts of the United African Congress for this webinar, Dr. Judy Kuriansky, who was also my professor at Columbia University at Teachers College, which is where I got my master's degree. It was also really great to hear about the very important health innovation exchange from Mr. Pradeep Krakatil, and thank you so much for what you shared with us today. I know that our other co-founder, Dr. Shariha Khalid Erickson, who's the managing partner of Machine & Co., spoke at your launch in Geneva. That being said, I'm very excited to introduce you to two representatives of the innovations that are featured in Health in Your Hands platform. The first is Simon Mbai, who is the partnerships manager at Medic Mobile, which is making valuable tools about health available online. Welcome, Simon. The floor is yours.
Thank you, Laila, for the candid introduction, and for the presenters before me. Well done. Mm-hmm. If I could be able to share my screen. Thank you.
Maura, I think.
Just a moment.
Yeah, he can share the screen. If you're having problems, I can share it for you.
Just a second, trying to find the correct one.
Why don't you let Maura do it?
Yeah.
Got it. Can you see my screen?
Yep.
Great. Thank you. Technology can be a hassle sometimes. As I mentioned, thank you, Laila, for that candid introduction. I'm just going to speak briefly about Medic Mobile and the Community Health Toolkit, and we're very pleased to be here and especially to represent Medic Mobile. Medic Mobile is a non-profit organization whose mission is to advance good health and human flourishing, especially targeting the hard-to-reach populations. We do serve our mission through our powerful open source software, built especially for community health systems. We work through partnerships with governments, implementing partners, as well as technical partners. We have a coverage of about 28,000 users globally, most of whom are in Africa, who conduct about 1 million household visits every other month. We have presence in Nairobi, where I am currently, Uganda, Senegal, Nepal, and the US. At Medic, we envision a more just world in which healthcare workers are supported to provide care, where universal health coverage is a reality and health is a secured human right. We also believe community health programs can deliver decentralized, integrated, and coordinated care, touching on what George had presented earlier. Our core framework, which we have designed and built over the past decade, is interoperable with other open source softwares, such as national DHIS, national HMIS systems, such as DHIS2, facility-based systems such as OpenMRS, and also it can be deployed at scale. Some of the core features and functionality which speak to the challenges around hard to reach populations is that it's able to work offline, support multiple users such as community health workers and their supervisors, amongst other frontline healthcare workers. It also provides longitudinal care through patient profiles, tasks and schedule management for timely and equitable care, and also has care guides for standardized quality care. Also, performance management for community health workers are things that we also track using our digital tools. In respect to COVID-19, we have been able to adapt our community health toolkit framework to support governments in COVID-19 response. A specific example in Kenya is we are supporting the Ministry of Health here for routine surveillance as well as community events-based surveillance and response. In Mali, we're also soon to launch a COVID-19 screening tool where we've already trained about 600 healthcare workers who will be manning specific hotspots around Bamako. That slide also goes to highlight to you what else we are doing around the space of COVID-19, which I'm happy to share resources later on for users or people here to actually read more about that. And I'm happy to stop there and to respond to any questions as a result of my presentation. Thank you so much.
Leila?
Thank you so much, Simon. Your innovations are extremely important in making healthcare accessible to those who are hard to reach. So thank you very much. The other innovation I want to introduce you to, which is also on the Health in Your Hands platform, is presented by Uche Umuego, the project manager for Theodore Biotechnologies. I'm excited about your projects and the development of the urine malaria test. Welcome, Uche.
Thank you so much, Leila. Thank you, Gordon. I am so happy to be here today. You know, what we do in healthcare, the stress is much, but at the time, I think it's worth it. So right now in Nigeria, as I was introduced.
Can you hold 1 second?
Leila,
okay.
hello.
All right.
Yeah, as I've been introduced by Leila, my name is Uche Umuego. I'm the project manager for Theodore Biotechnologies Nigeria. We are a US headquartered company and also a subsidiary in Nigeria where I'm taking this webinar from. So we are into product research and development globally. We're also into product sales, marketing, and distribution in Africa. Next slide, please.
Go ahead.
Yeah, I think he's just frozen.
Please, don't call me now.
Yeah, it's working.
Hello. Sorry, the network was bad. Sorry,
yes,
can you hear me?
Thank you.
Okay. So I said I am Uche Umuego from Theodore Biotechnologies, Nigeria. We are a US headquartered company right there in Baltimore, USA. And we have our Nigerian subsidiary office in Lagos, Nigeria, where I'm calling from, what I called in from. We are into products research and development globally, and also product sales, marketing, and distribution in Africa. Next slide, please. So we are in the business of delivering novel healthcare innovations that transform global healthcare delivery, bringing access to healthcare and helping others better their life. So most times, what we look at is what are the world challenging problems? What are the challenging problems in the world? No, growing up as an African child, I've always been, told to be very careful. Go inside the house. It's almost dark. You get malaria. And it's been like ages. So even before I joined Fayada Biotechnologies, I have been working in the area of malaria interventions with some organizations, some NGOs like FHI, Family Health, CRS. And what have we been doing? We've also been trying to make sure that people get adequate health care and also good intervention when it comes to community malaria interventions. Now, next slide, please. So looking at this very picture, it just shows exactly what happens at the healthcare facilities when people go to get treatment. You know, as a mother, your child gets sick at the middle of the night or during the day, you have to go to the clinic, you know, queue in line, see a doctor, get a referral to the lab, or even later on, come back again after the test must have been done and get a result for your test. Then probably go back again to the doctor for prescription. Now, looking at this, it actually discouraged some people not to even go to the facilities at all. So they decide to do presumptive treatments. Oh, I'm having headache, I'm having fever. And that means what I'm having is malaria. So we have almost more than 65% of treatments in Nigeria are done presumptively without adequate testing. So looking at all this, it motivated our inventor, which is Dr. Edi Agbo. He's actually a scientist that has worked with several organizations, including the prestigious Johns Hopkins University, which was very instrumental in the initial development and the production of our urine malaria test. So it prompted him to go into further research to make sure that we get a direct testing kit that will help tell people exactly whether the fever they are having is malaria or not. You know, remember, we have thousands of illnesses that present with fever, and you cannot just accurately say that your fever is malaria until you get a result. Next slide, please. So that brought us to this great invention, the urine malaria test. This urine malaria test kit is actually a development that took 10 years of successful clinical trials and also hard work to bring to the marketplace. We actually made this to help mitigate these challenges. You know, we have a lot of people in the hinterlands. Some health facilities that we have in the hinterland don't have microscopes even to start with. So most of them will just go to the healthcare to get healthcare at the facility. And even some of the nurses there also do presumptive treatment. They'll say, I've touched your hair or you're having fever, it could be malaria. So it now brings it to the fact that most people that get adequate healthcare are the people that are in the city areas than the people on the hinterland. Even the ones that even have microscopes, most times don't even know how to operate it. So it's actually a problem. After looking at all these things, we brought in our urine malaria test kit, which is a very simple tool. Do it yourself. Please, next slide. So it's a do-it-yourself kind of tool where you actually get a urine sample that any time of the day, as far as the patient is presenting with fever, you get a urine sample and put it in the urine sample cup that comes with the test. When you put it in the urine sample cup that comes with the test, you stand the test inside the sample for 25 minutes. And after 25 minutes, you read the result. If it's actually malaria, you have 2 lines. And if it's not malaria, you have 1 line. That means the person can go ahead and do other tests. So now it's interesting to also know that our urine malaria test dictates Plasmodium falciparum, which is more prevalent in Africa. Most other type of malaria we get here, we see that expectorate malaria, though we are also working towards that invention. Right now, what we are doing on COVID-19 includes, we've already designed a machine, a PCR-based mini lab that can actually be deployed into communities. They are very handy. You can actually take them into the communities, you know, run a test for COVID-19 within 2 hours, 30 minutes max. And what we're also proposing to the government of the day and every other African country is that whether we like it or not, malaria and COVID-19 presents with fever. And we need to find a way to do an intervention, to be doing interventions that we include malaria testing first, followed by COVID-19 testing. Because if we all focus on COVID-19 testing, that means the fight we've been trying, the fight against malaria, we're trying to get to malaria elimination in Africa. We might never get there because right now, the intervention on malaria is slacking while we're all looking at COVID-19. So it means that we are actually going to be going back to where we started. So with these few points, I want to believe that you must have understood what we are all about. And I must say that with the urine malaria test, we achieved 4 major things: accessibility, early intervention, non-invasiveness. So now you can see that our product is child-friendly and the kids love to hear that they can test for malaria without the needles coming to their skin. So these are the things we've done, and we are happy to take your questions. Thank you so much.
Thank you so much, Uche. Thank you to both of you, Simon and Uche, for your fascinating and important innovations that have an opportunity to greatly impact healthcare to people who are most in need. Thank you, and over to you, Mr. Tapper. Oh, I think you're on mute.
Thank you, Laila, you and your team. It's a marvelous group, and what they have imparted to us, I think, is very exciting. To be able to diagnose malaria by just dipping in urine is fantastic. Especially if you're living in the rural areas and you have to take a bus to go into the city or to some other medical facility. It's a huge benefit to us. I want to introduce my partners here, fellow organizers who will not be speaking actually. They're not speakers, but they will make some brief comments. Dr. Judy Koreansky, it's the one with the red hair. And below her is Mr. Milton Alimadi, who is the publisher of the Black Star News, important newspaper here in the United States, telling us about Africa. Dr. Mohammed Nur Hussein, wave. Dr. Nur Hussein, he is Professor of Medicine Emeritus in the State University of New York System at Downstate Medical Center. And he is the head of, a member of an Ethio-American doctors organizations that are building a state-of-the-art hospital in Addis Ababa. Right now, out of their own pockets, they have already broken ground. But I'd have everyone say a few words. Before I do that, though, I've gotten another text message from this ambassador from Sierra Leone to the United States, and he said he has not heard the name Sierra Leone called yet. So I'm going to invite him on now. To say, and he has no minutes. Maura, can you find him? Hello, Maura. Can you find Ambassador Y?
I did. He should be coming on as a panelist now.
Oh, okay. Very good. So he can lodge his own complaint. I shouldn't be carrying it for him. And that applies to you, Jennifer, to you, Laila, Uche, George, Pradeep, and Shirley, and Kimathi, all of you. All right, I'm sure he'll be on in a few seconds.
Okay.
I don't want him to text me again with his complaint.
He keeps flashing on and
I
off.
am, can you hear me?
Oh, there we go. Yes, go ahead, Ambassador.
Yes, I hear you.
Fine, thank you. Thank you so much. I'm so humble and delighted to congratulate the organizers of this incredible forum. You know, Gordon Tapa, Dr. Nur Hussain, Dr. Judy Kuriansky, and the brains behind this, the best publisher that we have in the United States, Mr. Milton Albadi. I listened very carefully to all of the presenters. What these individuals have done is what used to be extremely difficult for people at the side of the Atlantic to have a conversation with the creativity that is happening. Oh, sorry, Stephanie, and Stephanie too, I forgot to mention one of the brains behind this.
It's okay.
Yes, so whenever there are difficulties in the world, human beings rise up to the occasion to become very creative and innovative. So what I've heard from all of these presenters is just phenomenal. From somebody who represents a government, who is in government, who deals with these African issues, being the ECOWAS Secretary General for all Africa ambassadors here in the United States, and also the co-chair for diaspora engagement for the African Union. I am so elated and fascinated to know that things are happening over there around the world. I guess Deepak Kakati, the Predits, laid his finger on it. And I wanted to talk about that a little. The challenge we all face is how do we bring all these brains together to begin working together? That is the challenge. And I'm sure there is an answer. Africa, I should say, the issue of Africa CDC was developed, conceived by yours truly, Dr. Mohamed Nur Hussain, Gordon Tapa. They were the first people to talk about Africa CDC during the Ebola crisis. And today it has become a reality. Our governments, leaders, have come together to realizing that they can't do it on their own. So perhaps maybe under the leadership of Gordon and this group, I'll be very interested in seeing how we can pull these brains together, because you are doing it in silos. African leaders want to do it together. And those leaders like my president, Dr. Julius Madabio, and others, they're having their meetings to collaborate. So perhaps we will seek the indulgence of this incredible group of leaders to see what's happening. Look what she's doing in South Africa, what Jennifer is doing, what Uche is doing, George is doing, Simon is doing. There's gotta be a way that we could bring these processes together and use the instruments of government to say, you can't do it alone by no more. We need to cooperate. And through that cooperation, some of us will be happy to play a very tiny role. Dr. Judy is a board member of a COVID task team. For their information, we were the only organization in America, Australian Embassy, to create a COVID-19 task team. And we have raised some money, over $40,000, during this epidemic where people don't have any jobs. And we sought support from Argentina. Argentina gave us 5 respirators. Other people have given us some other things. So we have collected over $1.something million when everybody is saying we can't give anymore. So there is something that we could do. And we relied on the council and the support of people on this team. And Excellence Gordon talked about a major initiative that they were doing, they're going to do. So all of you could come together, and some of us could be your messengers to just take that message and to say, look at what your sons and daughters are doing. And yes, let's don't forget the Caribbean either, because that's part of Africa's 6th region. I yield back, Mr. Chairman, and thank you for giving me this simple opportunity to have to mark Sierra Leone present in the House. I thank you very much. I yield back.
Thank you, Ambassador White. Okay, we're at the end of the program. Stephanie, if you're there, I know you want to do a brief wrap up. Are you there?
Yes, I'm here.
I know you were knocked out. I'm glad you came back on. So please go right ahead.
Okay, so today we learned a lot, and I'd like to thank all the speakers for the wonderful job they did. Today, I just am going to summarize where we are and looking forward. We know that Africa accounts for 13% of the world's population, yet it bears 24% of the global disease burden, and it has 2% of the world's doctors. However, it has 1% of the world's health expenditure being used in Africa. It is estimated that $25 to $30 billion in new investments will be needed in healthcare assets to meet the growing demands in Africa. That's of a growing population and so on. Many countries in Africa, as we've heard, have a high level of mobile penetration, approximately 85%, and there's internet penetration is on the rise. Mobile devices have become increasingly common and have been adopted in many countries. In 2020, there will be 700 million smartphones in Africa, in fact, more than in North America. And they can be, as we've heard, a force for delivering better health care. There has been an increasing uptake of standalone mobile health via smartphones for patients. For example, we have Mom Connect, a mobile platform that saw 465,703 users adopt the service as well. The benefit of mobile technology is that it will increase access. It will also provide, reduce the barriers for low resources. And it also will also reduce the barrier of geographic distance, where millions of people are unable to access care. This can be overcome, as we heard today, by digital resources. Technology can be deployed to improve healthcare access and healthcare delivery. We can see we can use mobile phones, apps, telemedicine, 3D printing, like for plasters and so on, medical drone, because if you cannot go to the doctor, and in some places the doctor is 200 miles away, you can use telemedicine as an app too. Africa has been very innovative. For example, 1,000 government workers in Uganda, as described previously, use a mobile platform called M-Track to report on medicine stacks and supplies. During Ebola, the WhatsApp app allowed the BBC to use platforms to share life-saving health information in rural and quarantined areas. In Ghana, Novartis developed telemedicine, as we talked about as well. So other platforms include MT Health, M-Pedigree, and so on. And Nigeria has Ubenia, which is AI designed to diagnose childbirth asphyxiations by listening to an infant cry. There's also AI Doctor, which is powered to diagnose infectious diseases like malaria, typhoid, TB within seconds. Jennifer also talked about an important area. Also, we're going to talk about some of the targeted populations, refugee camps. So this could extend into areas where healthcare is not accessible. Technology can then be used in markets and churches and places with limited health resources. So AI presents that possibility, including building medical histories, medication histories, so that we can evaluate and prescribe. Now, Jennifer talked a lot about pathology, which was glass-based slides. Now with using WSI, we can now be able to use digital slides to be able, a new exciting era of diagnosing disease. So it takes again the patient to the doctor in different ways. So as she described, WSI allows the scanning of the entire glass slides and allows post-production. So basically, by scanning that entire slide, we now have almost a reproducible image of the diagnostic slide that we can then send by telemedicine to a doctor. It can also be used for quality assurance and so on. And then it can be sent to pathologists for second opinion. Once the images are digitized, they are exactly as a slide image. So thanks, Jennifer, for that. Now, how does that help? It also reduces errors in medicine, which is a common issue. One other issue that we should talk about is the health professional shortages. Some of these methods have caused a brain drain. So we need to look at 90% of the healthcare workers are in cities, leaving rural staff less in the rural areas. So we need to think about how we upscale staffing, and by using the digital methodologies, we could therefore bring the doctor to the patient. We have to leverage the training of doctors and nurses to make sure that people stay in Africa and do not leave for greener pastures. So the things to wrap up in final analysis, technology combined with health professional training, with incentives for health professionals to remain at home will be a winning solution. However, that doesn't mean we do not need to invest in healthcare infrastructure. It was wonderful to have a wonderful MRI, but with no electricity, it can become a flower pot. So we need to have electricity, water, and those things to combine. So as we discussed, we need to have investment in technology in the healthcare infrastructure. And we need to have more training of physician extenders. Now, one of the wonderful things I think I need to say in wrapping up, Africa has been innovative. There's lots of innovations taking place, and they're creating this boom. As Shirley talked about, we have Deftronics that uses solar-powered energy to power hearing aids. We have Zipline that uses drones to deliver medicines and COVID tests. We have smart jackets for portable diagnostic, and we have portable ultrasound for midwives. So healthcare professionals are the heart of this, but we need electricity, clean water, and available drugs. So what I would say, we're amazed at the leadership that Africa has taken to solve some of these acute healthcare problems, and it can be a leader in the role of smartphones, smart usage with limited resources. So I'm going to reiterate what Gordon says, Africa rise healthier and stronger.
Thank you very much, Stephanie. That was a fantastic wrap-up. Covered, very comprehensive, covered everything. This is our 6th webinar, and in each of our webinars, Dr. Judy Kuryansky, Milton Alimadi, and Dr. Nur Hussain have played an important role as part of the panel of experts. Now, we've not using the panel of experts today because the presentations made by everyone is so clear and just so fantastic. And in the chat box, I see people writing, how can I get this? How can I get this in Nigeria? How can I do that? You all can respond to that. But I want everyone just to have a word, to say something. But I also understand that Pradeep, if he's there, wants to say something to Ambassador Y. I think he been nudged by Ambassador Y. If he's there, he could come back on. So we'll wait for that. But
yes, he's there. I see him.
Okay, let's do that.
Go ahead, Pradeep.
Pradeep.
Gordon, thank you very much. And Ambassador, I think it's great that you put all of us on the spot by asking why is it that we haven't mentioned Sierra Leone. But one thing which I was just sharing with Gordon and with Judy was that we'd be very, very happy, because I do believe that solar might be an important solution, particularly if we want to make the health systems to draw on digital health. And we'd be very, very happy to work with you to support Sierra Leone. Maybe we can do one district initially to provide solar for primary health care, and then we can see how that works, and based on the experience we can look at scaling that up. But very happy to take that conversation forward with you.
Bravo. Very good.
That's fantastic.
Nice
and I know everyone here feels the same way.
Ready, amen. Thank you.
Okay.
Thank you.
All right. So we will follow up with that, and we're going to follow up with everyone here to make sure that Africa benefits from all of you. Now, I'll call on Judy and say a few words, then Milton and Dr. Noor Singh. Judy. Unmute.
We can't hear you.
And my dear friend, Ambassador Y, Ambassador of Sierra Leone to the United States, is exactly what a psychologist's dream come true is. And that is the connection between people on brilliant ideas, brilliant innovations, and a brilliant future. I am so thrilled and so happy. And I see that cross happening through all the presenters today, the brilliant presentations that have happened. Everyone, secondly, from a psychological point of view, who has acknowledged each other. So connections and acknowledgement that has happened today on this webinar is my dream come true and the dream come true for Africa Rise Healthier and Stronger.
Thank you, Judy. Milton, my friend.
Yes, comrades, thank you, all of you, for your wonderful presentations. I will probably follow up with some of you to do interviews for my publication, Black Star News. I just wanted to briefly ask Shirley, Professor, if you have a website for your business, could you share that website on the chat box in case people need to know more about your business related to plants and medicine? And I also want to propose that maybe in collaboration with us and Pradeep, we could actually do at some point and make it an annual event where we would have an annual meeting with all the ministers of health of African countries. Because I know you did mention that sometimes they're slow in embracing innovation. So I think if you bring them to an annual meeting and they see for themselves the efficacy and the benefit of this innovation, I think that might put them on task and encourage them to embrace the technology on a faster basis. And I think that would also make our comrade, Ambassador Siddiq, very happy. And then in terms of the absence of energy, that's always been the challenge, you know, even in terms of economic development in most African countries. And so I'm glad that Pradeep spoke about why don't you use something that you have in abundance, which is sunlight, right? So solar energy, maybe we can also do a webinar focusing just on solar energy and its benefits for African countries. And Pradeep might, you know, want to be a part of that, or maybe he can suggest people that we can bring on to such a webinar. But overall, I just want to thank everybody for their brilliant presentation. I also, maybe Uche, you can also let people know the affordability of this amazing testing kit for malaria. But thank you, everybody. And I learned quite a lot. I almost feel like, you know, I'm even willing to pay for what I learned today. Back to you, Gordon.
I can give you my account details. Dr. Noor Singh. Unmute, unmute.
Hello, can you hear me?
Yeah.
Hello?
Yeah,
Okay.
can you hear me?
Yes.
Yes, can hear now.
Yeah. This has perhaps been the most exciting webinar we have had to date. And to hear the kinds of innovations that are happening in Africa are really game changers in the way healthcare is going to be accessed and delivered, both in Africa and worldwide. I just thank the presenters. They were magnificent. I would also like to echo my colleague Judy, that Ambassador Siddiq, of course, as usual, is about connecting people. And he did show that today. In his other life, of course, for some of you who may not know, he was the founder and longtime president of the United African Congress, with whom we have had a wonderful collaboration over the years. One question, not question really, sort of concern I have is about these innovations have always been followed by escalating costs in medicine. With every introduction of new technology, the healthcare cost has been rising. At least from my vantage point here over the last 30 to 40 years in practice. This new technology, I hope, doesn't lead to that kind of, because the idea is really to improve access to those who can, least afford it. So, in addition to access, it should be affordability in the mix, in the consideration. I'm glad to know that Jennifer mentioned one of the benefits of the digitizing the pathology was lowering the cost. I hope that will be the case with all the new innovations. And again, I thank each and every one of the presenters. Remarkable, very fascinating. Thank you.
Okay, thank you, Dr. Nur Hussain. We're at the end of our program, but before closing it off, I wanted to let Shirley know, and that we had discussed holding one webinar on African traditional medicine. And that wasn't intended to be today, but guess what? You did it. And it's fantastic that you actually did that. And African traditional medicine, herbal medicine, we do this include Ayurvedic medicine and other alternative forms of medicine and treatment in one webinar at some point in the future. So with that, I want to thank you all. It's been fantastic. Thank you, Jennifer. We're not going to let you go. Laila, we're not going to let you go. George, you're with us. And Shirley, you're with us. And all of you are with us from this moment on. Take care and thank you so very much.
Thank you.
Thank you. Thank you so much.
Okay.
Thank you very much.
Dr. Judy, Dr. Nur Hussain Milton, hang around. I'll send you another text.